Good morning and welcome to the 9th Annual State of the Public Health Conference in Georgia. For those who are new to our conference, I am Marcia Davis, Dean of the College of Public Health at the University of Georgia. There are no words to describe what the world has been experiencing over the past year. A global pandemic and the health and socioeconomic inequities that it has exposed, long overdue reckoning with systemic racism, blatant injustices, violence, words and acts of hatred, the politicalization of science, and most recently, we witnessed divisiveness that threatens both our democracy and our health. In my lifetime, our world has never needed more the experience and perspective that public health offers. And that is why we could not let this year go by without convening the State of the Public Health Conference. While we might be virtual this year, our purpose is the same: to celebrate those who have stood in the face of this year's challenges and carried out the work of public health undaunted, to learn from exemplary work to advance our knowledge and practice of public health, and to inspire us for the work ahead. So let me now ask Grace Bagwell Adams, our new Assistant Dean of Outreach, Engagement, and Equity, to orient us to our morning together.
Thank you so much, Dean Davis. I'm honored to be here. I'm Grace Bagwell Adams. I'm the Assistant Dean for Outreach, Engagement, and Equity in the College of Public Health at the University of Georgia. Just want to echo her sentiments of welcome and gratitude for you being here this morning for our conference. I'm going to go right into doing an overview of the agenda very quickly. The first thing on our agenda, we have with us Dr. Amber Schmidtke, and she will be giving the first keynote on data access, data transparency, and public health communication. We will then transition into our breakout sessions. We have 3 breakout sessions planned for you this morning, one on COVID vaccine and vaccine hesitancy, the second on behavioral health, specifically the opioid epidemic in the state of Georgia since COVID-19 has hit. And then the third, a session on health equity, where we have some racial justice work highlighted that's being done by the Texas Health Institute. After the breakout sessions are completed, we will then transition back together to the main conference, and we will have some spoken word poetry shared by S.J. Henderson. And once S.J. has performed, we will then transition into our closing keynote from Dr. Renée Canady before we have our closing remarks by myself and Dr. Davis. So again, thank you so much for being here. Just a couple of technical notes. We're going to have some polls to gauge your interest and impression of the conference. And we also just ask that you stay logged in to the session for the duration of the conference. It is now, without further ado, that I introduce our first keynote speaker, Dr. Amber Schmidtke. Dr. Schmidtke, it's our great honor to have you here this morning. You have truly been a force in the state of Georgia and have really helped all of us have more insight into what's going on during this critical time of the pandemic. Dr. Schmidtke is a medical and science educator and a self-described public health microbiologist. She holds a Ph.D. in medical microbiology and immunology. She has worked at the CDC as a microbiologist and has served on the faculty as a professor at Mercer University. She currently serves on the Georgia COVID-19 Data State Task Force, has a podcast called Podcast for Public Health for the People, and is a science writer for sharing COVID-19 in Georgia context, national context, global context. If you have not yet signed up for her fabulous 3 times weekly updates, I encourage you to do so. I'll share that link in the chat. But Dr. Schmidtke has really, I believe, transformed access to some of the most important data points that it is really for all of us to understand what's happening with the pandemic, both in terms of incidence, prevalence, and healthcare use across our state. And she's done so in a way that has really educated, I think, so many people, thousands of people that have subscribed not just to her listserv, but of course that have followed her on social media. So in addition to introducing you, Dr. Schmidtke, we must also just say thank you for really opening the door for so many of us to become more familiar with some of the complex public health data that have been so critical for us to access and understand during the pandemic. Without further ado, I'm going to turn it over to you. Thank you so much.
Wow, thank you for that introduction. And I want to thank you, Dr. Bagwell-Adams and Dean Davis, and really the entire UGA School of Public Health for your gracious invitation to participate in this conference and be your keynote speaker today. It's an honor and not an honor that I take lightly, so thank you. I look forward to learning about things like vaccine hesitancy and health equity today in this conference. There's a fantastic lineup set up for you. And I especially look forward to the second keynote to close us out by Dr. Canady. I also want to thank all the folks behind the scenes that are working to make this a great event, and I hope that you're going to learn a lot today. This is, as Dr. Davis pointed out, such an important and chaotic era in history. I often tell my children to make sure to look up and pay attention because these are historic generation-defining times. But like them, I think all of us are a little tired of living through so much history. And you know, when we live through historic times like this and we have a key role in working that history, it can feel hard to escape from it. And so today, I think really is meant to just be an opportunity for us to connect with one another and sort of celebrate our successes and really look to what we have left to do. So I have to tell you a funny story. As I was rehearsing my talk for you for today, yesterday, my husband came up and reminded me that this is not, in fact, a media interview where I have to deliver my key message in 20 seconds or less. So I'm excited for this chance to really dig in and share some ideas and things that I've seen as I've learned alongside all of you about how to communicate with the public through this pandemic. So some of you may not know who I am or why the UGA School of Public Health has asked me to be here. Or maybe you do know who I am, but you don't know the story of how I got involved in all of this. So today I'm going to share a little bit about that story and also talk about how we capitalize on this unique period in history to improve science literacy and improve public trust and public faith in public health. As Grace pointed out in my introduction, I spent 5 years in Omaha, Nebraska, earning my Ph.D. in medical microbiology and immunology from Creighton University. And that is a small Jesuit school that most people don't know about except for their basketball program. Throughout college and graduate school, I was raised to be a good communicator, and that's really served me well as an educator and during this pandemic. My doctoral dissertation examined the genetic mechanisms that linked cell wall recycling pathways in bacteria to antibiotic resistance, namely AMP-C beta lactamases. And that work was really clinically relevant, but as a young person, I really wanted to do something with a more far-reaching impact. So as I was writing and defending my dissertation, I applied and was selected for a really competitive research fellowship program that's sponsored by the Association of Public Health Laboratories. And they really kind of helped me get my start. So through that program, I matched to the pertussis and diphtheria laboratory at CDC, where my branch chief was none other than Dr. Nancy Messonnier, who has been one of the most visible and vocal spokespersons for the CDC effort against COVID-19. I arrived at CDC in January of 2009, which was just in time for the H1N1 pandemic that would unfold later that year. So I got to see pandemic response from inside a public health agency, and that was an incredible education. My research project there was actually to do molecular subtyping or genetic fingerprinting of Bordetella pertussis isolates in their collection dating back from 1935 to present day to see if there were any changes in the population of those bacteria in relation to the US vaccine policy changes. So when it came time to publish, you may or may not know that there's a significant clearance process at CDC to make sure that your science is sound, not over-sensationalized, and fair. And I remember going back and forth with Dr. Messonnier about the conclusions. I, a young person, new to the field, wanted to issue declarative statements. She wanted caution. And as often happens, the boss wins that argument. And to be fair, I was young and, like I said, and not fully versed in speaking diplomatically. That's gotten better. And eventually the study did get published, and I finished my postdoc and then moved on to food safety at CDC, joining the PulseNet team. So a side story to all of this is that I've been a military spouse for the last 18 years, and you may have heard that the military moves around a lot. So my time at CDC wasn't going to last forever, but it was a really emotional thing to leave that work, that field of public health, and to be so deeply involved. And I miss it all the time. As I've tried to stitch together a career across multiple moves and even had some duty stations where a Ph.D. closes more doors than it opens, I've continued to be guided by a desire to serve and to make a difference. So I've spent some time doing community organizing and advocacy, working with city councilmen and county commissioners to get paid family leave policies passed by the cities of Warner Robins and Fort Valley and Macon-Bibb County. I've also helped a good friend run for office for a largely rural district as her campaign manager. We didn't win, and that's okay, because she was a first-time candidate and I was a first-time manager, and we really were kind of building the plane as we were flying it. But it was a profoundly educational experience for me to see the important needs of rural Georgians and how to best meet them where they are, and to see the community that they share. For the past 3 years, I've been an educator, first to undergraduates and then to medical students, most recently at Mercer University School of Medicine. And that was just another great opportunity that I deeply loved that was unfortunately cut short by my husband's military service. We actually live in the Kansas City area now, and that's where I'm talking to you from today. So given my experience with Dr. Messonnier and her penchant for cautious public statements, when she came out to the media in late February of last year and said that this pandemic was going to have a profound impact on day-to-day living, I knew it was the real deal. I relayed her message to my friends, my family, and my students. I warned them to make sure they had food on hand and medications on hand, expecting that there would be a lockdown at some point. I'd long been a resource to friends and family who were scared of recent infectious disease diagnoses, who didn't feel like their doctor was explaining things to a level that they could understand, and questions about vaccinations and whether their child needed an HPV vaccine, et cetera. So, and at that moment, I had a lot of worried friends. My own little family fired up the deep freezer in the garage, and we stocked it little by little over the next month, as maybe you did too. But over time, I began to see that Dr. Messonnier and other public health heroes that I'd worked for, like Dr. Ann Schuchat, were being increasingly sidelined in getting the word out to the public. My students were adults, all of them college graduates now in medical school, but they were first-year medical students with exactly one semester's worth of medical education under their belts, and they were scared. And while they weren't my children, they were somebody's children. And if it were my child in that situation, far from home, I would hope that there would be an adult in their life who would be a source of comfort and strength when I couldn't, who would be honest, but also compassionate and reassuring. And during a crisis, I think it's human nature to want to find a way to help. So it was at that time, as the people that I looked up to do the talking were silent, that I looked left, looked right, and realized that I had a role to fill. It's actually because of poor science communication during the early stage of this pandemic that you know my name at all. So I offered an impromptu briefing to the students, or my students, of what we knew so far about the virus, what public health measures might be taken, and how they could prepare. A few days later, I was asked to give an expanded version of that presentation to the entire student body of Mercer University, its faculty, staff, and administration. That was Friday, March 13th. Afterwards, the decision was made to close the campus the following Monday, along with my children's school district. Like many educators, I spent the next 2 months figuring out how to teach online and how to facilitate group discussions via Zoom, while also managing my children's home-based online education. I answered questions for the local school district, university administrators, fellow faculty, the infectious disease team for the hospitals in our area, and for family and friends via social media. The social media thing kind of expanded rather rapidly over time, and because it turned out that people really did want to know how to evaluate the data. And at that time, the state of Georgia was providing daily updates, but they were just daily cumulative totals. We weren't seeing data in any context of time. So I taught people what the different sources of data were, how to read them, and what the trends meant over time. Eventually, social media postings turned into a newsletter on the platform Substack, and that's called Georgia COVID-19 Updates. As of yesterday, it's ranked the #1 health newsletter on that platform. Eventually, I captured the attention of the Department of Public Health, who invited me to join the state's COVID-19 Data Task Force, a group of professionals from DPH, GMA, the Geospatial Information Office, CDC, Georgia Tech, MIT, the Georgia National Guard, and the dashboard web developer called Esri. The crux of the mission was gathering the data we needed and turning them into useful tools that could guide decision-making both within the state government and also for the public. My role in all of this was always to ask the question, how is the public going to use this and understand this? How are we going to make the data useful for lay people? I was effectively the communications person for the task force, writing and approving much of the public-facing explanations, captions, and pop-ups, especially on the GIO Data Hub. Because of my work on social media and my newsletter for the COVID-19, I had the pulse on the questions that the public was asking, the pitfalls in the data that were leading to disinformation efforts, and that helped to guide some of the data that we were ultimately able to provide and how we presented it. The task force has kind of stood down since August when we ran out of CARES Act funding, but I do remain in contact with all of the members of the team and continue to work for greater clarity in the way that the state provides data to the public. Through all these efforts, my outreach grew as I tried to teach people how to access and read the state's data and to communicate the risks and strategies that people could use to save lives. There was a real desire to quickly and better understand, and my student body jumped from 60 students to 60,000 really quickly. As I mentioned earlier, my family moved across the country in August. And trust me, moving during a pandemic is a whole nother story that we could tell at another time. When you're deep in the data like this, it can be kind of an anxiety-driven thing. We actually live near Kansas City now, but I've lived in Georgia for 9 years combined, and that makes it the state I've lived in the longest. It's home, so I'm still talking about it. And I've transitioned from being a medical educator to a freelance science communicator and writer. My days are spent analyzing data, communicating them to the public, doing a lot of media interviews to inform the public, advising government officials, school superintendents, and the judicial system, while advocating for better public health funding and staffing with elected leaders. I have no idea where freelance work is going to take me. I don't exactly have an example to follow, and I'm largely charting my own path. But it has given me the flexibility to shepherd my children through virtual learning during a pandemic while serving my community. Like this pandemic, it won't last forever, but I'm happy to ride this momentum while it's here, and I will be one of the loudest people cheering when this pandemic finally ends. In the future, when we all have a chance to catch our breath, I want to make sure that Georgia's pandemic story is told through the data that I've been able to generate, the experience I've had working with all sorts of powerful people, and the contemporaneous notes that have chronicled our journey through the pandemic as it was happening. I don't know if that will take the form of a book or simply putting the documents and data in a library, like at the UGA School of Public Health or Mercer University School of Medicine. But I think we all need to contribute what we've learned and experienced for the generations that follow us and study this unique period in history. We all have stories to tell. So enough about me. Let's talk about some science communication. And to start, I think we need to spend a moment thinking about the lessons that we've learned in this pandemic as it has been happening. One painful lesson, especially for me, that we've learned during this pandemic is that there's a large portion of our population that is unmoved by data or the suffering of others. And that's a really weird thing for public health to confront when, by our very nature, we care so very much about those things. No one goes into public health for riches, fame, or glory. There are certainly easier ways to make money. It is instead a calling to serve our communities, to put the needs of our communities ahead of our own. And it feels strangely foreign to learn that a big chunk of the public that we work so hard to serve and protect does not feel the same way and is not necessarily our partner in that mission. Teaching people to care about each other is not one of public health's missions, but it's needed nonetheless. And I'm hopeful that someone will step into that role. By the start of 2021, just a couple weeks ago, the globe has suffered so much death from COVID-19 that it is 3 times the number of Jews killed in the Holocaust. Each day since the start of the year, America is losing as many people or more as we did on 9/11. It's important to have these reference points, as painful as it is to think about them, especially as the numbers we're recording become so large. And that's because humans have a hard time wrapping their mind around big numbers. But public health professionals know that these aren't just numbers, they're people, lots and lots of people. Yet a substantial portion of my time is spent in science communication devoted to dispelling disinformation that seeks to downplay the severity of this pandemic. And I would bet that disinformation occupies a fair bit of your time too. Unfortunately, the communication strategy for this pandemic, especially at the federal level, has been chaotic, contradictory, and it has exacerbated the crisis. If and when CDC was able to get a message out, it was immediately corrected by the White House, and often in a contradictory fashion. The White House Coronavirus Task Force took over the roles of communication for the pandemic, but the recommendations they made to states and to the public were not made available to the public. The only reason we have them is because of open records requests to each of our state governors and departments of health. And however well-intentioned those reports and recommendations within them may have been, they were often contradicted by political messaging. So it has been hard for people to know what to believe. And when that happens, people tend to go back to their tribe or faction. But the reality is that we have a scientific problem that cannot be solved with political solutions alone. I can't help but wonder how different things would be if public health was able to operate with full support and optimal efficiency. I wish so much that the leaders in public health had been able to communicate directly with the public on a regular basis, and that there had been unified messaging to limit the impact of disinformation and politicization. Because in a pandemic like this, it's critically important that every household in America receives the same message regarding the risks and safety. And the contradictions between public health guidance and political messaging have led to big differences in the way that political factions see the pandemic and their risks and responsibilities in limiting transmission. The polling firm, Morning Consult, has been polling Americans regarding the pandemic for months now. They have found, as of their most recent poll, that 52% of Democrats consider the pandemic to be a severe health risk for their community, compared to just 30% of Republicans. It's probably not a surprise then to learn that Republicans are about twice as likely as Democrats to still socialize in public places. And that makes sense, right? Because after all, if you don't see the pandemic as a risk, then why would you change your lifestyle? In public health, there's a tendency not to talk about politics. And so if you're squirming in your seat right now, I completely understand. And I don't say any of this to poke a stick in anybody's eye. But when the messaging is as important as it is in a pandemic, it's important for us to know where our communication gaps are so that we can fix them. Instead of a coordinated communications strategy across the nation and in states, the responsibility of communicating the pandemic to the public has fallen to people like me and so many others in other states. We've seen experts from all sorts of disciplines lend their expertise to this public health effort because the stakes are so high. I can speak from experience that becoming a public figure is a surreal thing and not without risks. But it's totally worth it to me because even if it saves just one life in this pandemic. This grassroots science communication has been a team effort too, and it's beautiful in its own way. But it's not the way that things were meant to be done. And it has cost lives to not have consistent and unified messaging that has reached every state and every county in this country. I will always wish that I could have done more, covered more states, had better access to data, and so on. So we see some of the ways that things have gone wrong. So now we need to think about our role in this unique time in history. What will we tell our children and grandchildren and the students who follow us about what we did during this time when we were called? Generations that follow us will study this period in history to try to better understand the lessons that we learned. And as tired as we are, public health needs to tell its own story of what happened here so that future generations will be better prepared when the next pandemic comes. Write down those moments that mattered to you in your work. Share them with your friends, your family, a blog post, a social media post, a publisher, etc. At one point, I remember having a conversation with my medical students who didn't really know much about public health about the difference between the way that a medical doctor sees the world and the way that a public health professional sees the world. And that's not to say that we don't have MDs in public health. We have a lot of them. And we have veterinarians and nurses and all sorts of disciplines too. But we are very much on the same team, just addressing different parts of the problem. But whereas a medical doctor in the traditional sense sees the patient in front of them and is focused on their well-being, for people in public health, our patient is an entire community. And so the way that we gather data and the way that we diagnose problems is different too. What both fields have in common, however, is that they rely on a team approach when caring for their patient. And I know many in attendance today have worked themselves to the bone in this pandemic, as underfunded and overwhelmed public health districts try to shoulder all the burdens for testing, contact trace investigation, and now add to that a mass vaccination campaign, in addition to all of your usual responsibilities. You may be thinking, Amber, I've got nothing more to give. And if that's true for you, that's okay. If your plate is too full, then you do you and keep things moving forward in your sphere. For many of us, though, I think that we may have the bandwidth to carry the water of public health messaging because our communities, our state, and our country are worth the effort. So how do we turn this around? How do we improve science communication going forward? You know, often when public health works well, you often don't even realize that we did anything. If public health isn't in the news, then we've done a tremendous job. But that silent success for public health is part of what led us to the failures of the American response to the COVID-19 pandemic. When politicians brag about their achievements to their constituents, investments in public health are not among the glamorous highlights, but we still need to demand them. And it can be really hard for public health to advocate for itself when so many of us work for government organizations, whether they are local, state, or federal. And in those settings, political advocacy, even self-advocacy, is often frowned upon. But we now see what not advocating has done for us. We have seen big cuts to staffing and funding for public health over the last decade, and that has meant that everything about our pandemic response has been painfully slow and ill-equipped, from testing to PPE stockpiling and procurement to dashboard design and vaccine deployment. Infrastructure is not built overnight, and neither is expertise. I don't say any of this to offer excuses, but I do wish so much that America and Georgia could have a do-over in this pandemic with the proper funding and staffing in place. I would love to see what public health could do when operating in its top form. So we need to find the balance between objectivity that allows us to do our job well and advocacy. We need to be able to stand up and speak out on behalf of public health as an industry for funding as well as staffing. No politician is going to fight for public health funding unless we ask for it. And it really should be a bipartisan issue anyway. As this pandemic has shown, this virus does not care who your political affiliation is. If we can stay issue focused and avoid partisanship, then I think it is possible to walk that fine line that gets public health resources, the resources that it needs in order to best serve its communities. But public health also needs to find its voice in order to take back the really loud microphone from those who wish to disinform. Because for all of the rhetoric that we've seen over the past year about among our politicians, guess who remains the most trusted source of information in this pandemic? Our elected leaders are at the bottom of this public trust ranking, while CDC, the most recognizable public health organization in America, is ranked #1. So yes, public health has, public trust in public health has fallen, but we remain the most trusted leaders for this pandemic. The public does want to hear from us, and when we don't speak, it leaves a void for disinformation to fill. Our public does want to hear from us, and we do have things that we need to tell them. But in order to do that well, we need to know who our audience is so that we can meet them where they are and bring them along. Because so much of our efforts in mitigating the pandemic depend on public trust. And despite the fact that the earliest vaccines are in use now, we still are not close to the finish line. We need public trust and public buy-in now more than ever. As of January 2nd, only 50% of Americans say that they're willing to get the coronavirus vaccine, whereas the herd immunity threshold is probably closer to 70 to 90%. So how do we move forward towards that? And that's why I'm really looking forward to the breakout session that follows this on vaccine hesitancy. So let's start to identify the gaps in knowledge and gaps in expectations, starting with an expectation from the public. We live in a society that is built on immediate gratification. Our public is used to fast answers, and they expect fast answers from us. And there is a portion of our society that will listen to anyone who can give them the fast answer. This can include things like, you don't need to wear a mask, just take extra vitamin D. And you don't need to stop going to restaurants, just take hydroxychloroquine. However, in public health, as in many other areas, just because an answer is slow does not mean that it's wrong. Until we reach herd immunity through the vaccine, the very best defense we have against this virus is our non-pharmaceutical interventions, and those depend on collective effort. The incubation period and asymptomatic infections associated with COVID-19 further exacerbate the problem because people don't get to see the immediate impact of their actions. So we don't get the positive and negative reinforcement to do the slow but necessary work of limiting disease transmission. Given our public's short attention span and demand for instant gratification, it has been even more important to have clear and consistent messaging. Unfortunately, we've fallen short. So next, let's talk about a knowledge gap. In recent years, we've seen expertise devalued in politics and public culture, or popular culture, excuse me, and we have somehow arrived at a place where people consider all opinions to be equal, even if some are wrong and have no basis in fact. We also have a segment of the population that struggles with critical thinking and understanding data, or even worse, they find data to justify their narrative, regardless of the scientific consensus. I would argue that a key knowledge gap that put us in a poor position at the start of this pandemic was science literacy and critical thinking. As a science educator, I see this pandemic as a second chance to teach science and critical thinking to those that may have missed it in their education, either due to lack of interest or maybe they didn't connect with their instructors while they were growing up. The scientific method is something we all depend upon in public health, but it's not necessarily the way that the world or the public sees the world. Our public started this pandemic with a very limited understanding of the scientific method, peer review, and how scientists communicate. They don't see the distinction between something printed in Newsweek magazine as compared to the New England Journal of Medicine. The research papers that conflict with each other can sometimes give the public the impression that science doesn't know what it's doing. But of course, all publications are not equal, and more often than not, the conflicting research findings are part of the self-correcting collaborative nature of the scientific method that helps us all to gather more evidence and improve our hypotheses and move knowledge forward. Remember that I said that the public wants fast answers? Anyone who has published can tell you that it takes months to years to design a study, acquire funding for it, gather data, analyze them, and then write, edit, and make it through the peer review process before publication. On the contrary, conspiracy theories are fast. Controlled studies and peer review are not. So science will always be behind. Disinformation has accompanied the field of public health since its very earliest days. We are not going to get through to everybody, but I see value in reaching those we can with information that can save lives or improve their quality of life. So how do we take back that microphone from those who seek to disinform and misrepresent the data and in this pandemic? That begins with speaking up in the first place. Everyone here with a science or medical background is an ambassador for science. We have a responsibility to share good information calmly and consistently. And if enough of us do this, guided by what we see to be good science, then we will demonstrate to all who are watching that there is actually more consensus in science than discord. Think of it this way. If the main message people are hearing via social media and elsewhere is the half-baked opinion of someone with no science or medical training, but the scientists around them are silent, then which message do you think those people will hear? The hardest thing for us to do is start, and I know it's scary. Our public has limitations when it comes to understanding science and public health data. However, in my experience, I have found that they are capable of learning and very eager to do so. I guarantee you that today, more people of the public can tell you that why there's a 14-day window of uncertainty in the case and death curves than they could a year ago. A year ago, those were foreign terms. They see the value of a 7-day moving average. However, we have to do more to teach them, to orient them to what they're looking at. For many, the last time they looked at data in graphs and charts was in high school or college. A surprising number of people can't find their own county on a map. So we need things like landmarks and pop-ups. Our public does need help getting their bearings. What do the axes mean? What are the data showing? But if we can teach them how to read a graph for themselves, then they'll get more comfortable forming their own conclusions and using data to make evidence-based decisions. Our public is less community-oriented than they were in the past, unfortunately as well. My husband and I have discussed this multiple times that we don't think America would survive World War II if it were happening today, with all the rationing, victory gardens, military drafts, et cetera. There just isn't that sense of community before self. And so what that has translated to in this pandemic is that we have seen moral arguments that appeal to people to do the right thing are falling on deaf ears, because there are just too many people in our society that have a, forget you, I've got mine sort of mentality. And that's a moral failing that public health isn't really equipped to solve, but it has nonetheless made our job more challenging. So knowing more about our audience and knowing that they do want to learn and hear from us, how do we begin that conversation? How do we start talking to them? I think one place to begin is just by being approachable and available. Let your contacts know that you're passionate about public health and science, and that you're willing and eager to be a resource for them as they try to find information or make decisions. For me, it has been critically important to keep my political beliefs separate from my science communication. I'm a human and obviously have political opinions and beliefs, but my political opinion is not worth as much as someone else's life if it alienates them from hearing a public health message. So be humble and honest if you don't know the answer. Be consistent and data-driven, working to make the people around you more data-savvy consumers of information. Discuss the importance of evidence-based decision-making and discuss what your trusted resources of information are. Use analogy and put science into real-life context whenever possible, even outside of the pandemic. But I don't want you to be discouraged if you put yourself out there and someone doesn't get it, or someone reacts emotionally to what you have to say. So this next piece of advice is hard. View questions as honest attempts at learning rather than an attack on your ego or expertise. And understand that a lot of people have a lot of fear right now, and everyone is just trying to do the very best that they can. When people lash out, understand that there is often something going on underneath the surface that's driving that. And if we can connect to each other on that human level first, then the important message that we need to deliver has a chance of making a difference. Diagnosing those misunderstandings is really no different than diagnosing a gram stain, but we use social skills rather than laboratory equipment. In the earlier days of my work on this pandemic, I've now had strangers commenting and following me on social media, and I had one woman exclaim, "We don't need your stinking graphs." What a funny thing to say. But when you think about it, that's really not an attack on me. I didn't offer any commentary or analysis. It was just a graph. And this woman was threatened by data, just data. So I started asking questions. What bothers you about this graph? Okay, why do you say that? And eventually you ask enough questions that the other person reveals something that you can either solve, or it reveals that their objection is really sort of silly and rooted in something that's irrelevant to the issue at hand. Another example, it's always a woman, it seems, but it was a woman from coastal Georgia who lambasted me on social media saying that I was making up the hospital numbers that were copied and pasted directly from GMA for the Savannah area. And this was right around the start of the summer surge. And if you recall, the summer surge really sort of started in coastal Georgia and then spread throughout the state as vacationers went home after Memorial Day. So again, my data came directly from GMA, and so there was no way I was lying about them. And I was citing the work, and I was still being accused of lying. So looking at her profile, at first you could be like, what in the world? What is this woman talking about? But if you looked at her profile, I could see that she was a small business owner, and her posts indicated that her small business was in trouble due to the economic fallout of the pandemic. So at that point, the conversation really changed in a big way for me, because it wasn't actually an argument about data. This was someone having an emotional response to something that she couldn't control. And haven't we all been there at one time or another? She was attacking me, but I wasn't actually the source of her problem. I acknowledged the difficulty that she was experiencing and expressed sympathy for the ways that this pandemic was affecting her business. But the pandemic is the root cause of the economic fallout. And if we can address the pandemic, then economic recovery will be faster. If we can convince more people to wear masks, then there are aspects of regular life that can resume, including shopping. So I told her that my goal in all of this was about communicating those risks, to limit transmission to a point that we could save lives, but we could also save a local business like hers. She ended up thanking me by the end. So again, I could have seen this accusation and taken it personally as an attack on my expertise. But if we can pause and see what's motivating that accusation, then we can address that concern and have a productive dialogue. The important thing here is that she did eventually hear the public health message. And as my readership has grown, I've not been able to do this kind of root cause analysis or question answering as often as I would like. And I no longer, like I said, have time to answer as many questions as I'm getting. But I do know that I'm asking you to take a big, scary step out of your comfort zone. And I don't want you to flinch or give up the first time someone doesn't agree with you. So if that helps, if that story helps you, then great. For the non-scientists who may be in the audience, I have advice for you too. Share quality information whenever you can, and avoid clickbait or things that are meant to sensationalize. Go beyond the headline and read what you're sharing. Use data and evidence to drive your decisions and encourage others to do so too. And when it feels like maybe your news sources have a bias and you don't really know what to trust, then go directly to the data. If you don't understand the data, then find someone who can and ask them for help. I just told a whole bunch of scientists to let you know who they are, so go find them. Be open to changing your mind, and if the data contradict your thinking, then be prepared to change your thinking too. Examine your own sources of bias and how they contribute to your decision-making and perception of the world. Ask questions and be curious, and don't ever stop learning. This is a long-term relationship that we need to build with the public, but we can make significant inroads even in the short term. And here's really one of the reasons why this relationship matters as much as I think it does. How do we take a number like 50% of the American population saying that they'll take the COVID-19 vaccine when it's made available to them and drive it upward toward herd immunity? As I highlighted earlier, we know that it might be harder to convince Republicans and independents. How do we reach them? We know that there is justifiable distrust of the medical establishment among people of color. How do we reach them? This pandemic has been disproportionately worse for rural counties than urban and suburban ones in terms of death rate. So how do we reach them? Each one of these people, I should have a slide coming up in just a second. Each one of these people, each one of these communities has an ideal messenger. Thank you. And that ideal messenger is the person who is more likely to make them change their mind. Take a look at another poll that shows us who people say would make a difference for them. Some of the people who are most trusted are family, friends, and public health leaders and medical professionals. You all have friends, you all have family, and you are all public health leaders and medical experts to your community. You are science and vaccine influencers. You actually have more influence than Beyonce or Tom Hanks. And if we can get enough of us talking, enough of us answering questions regarding vaccine safety or efficacy, and getting people the information they need to feel confident in their decision to vaccinate, then we move the needle upward, closer to the end of this pandemic. But it is a heavy lift to get us from 50% to upwards of 70 to 90%. So I think it's going to take all of us. The COVID-19 pandemic is obviously disrupting everyday life for so many people, but we have the attention of the public and a second shot at improving science literacy and coaching them to make evidence-based decisions. And really the implications for this go beyond COVID-19 and will impact the public conversation in other pressing areas of science and medical importance, including things like health equity, climate change, water and air quality, conservation efforts, vaccinations, and the next pandemic. We cannot throw this chance away. In a crisis, so many people want to do what they can to help, to pitch in. I cannot save a COVID-19 patient who is struggling to breathe. That's just not where I specialized in my education. But I find comfort and camaraderie in knowing that I am part of an enormous global team. I hope that you see that too. Instead, the way I've been able to pitch in is to communicate the risks, teach the public how to read and interpret data for themselves, and encourage them to make those evidence-based decisions. Then they join our team by taking actions that limit disease transmission. The more people we can bring to this effort, the faster we reach the glorious end of this pandemic. Just like you, I have hard days too. And there are parts of this role that I don't love. Hate mail and my Pavlovian response to be near a computer at 3 p.m. every single day, not taking a day off since mid-March. But I love data. It, provides me comfort during chaos, and I'm sustained by the knowledge that people depend on the information that I provide. I know that the burdens of frontline healthcare workers will be lighter if I can convince more people to choose caution over carelessness. The work that we do together saves lives, and I cannot imagine a more noble effort right now. It has been some of the most important work that I've ever done, and it's been the way that I've pitched in during this period in history. So thank you for this opportunity to serve my community and to make a difference. In closing, I will just say that times of extraordinary challenge inspire moments of incredible courage and compassion. We see the proof of that every day. As tired as we are, I want you to know that the work that you're doing matters. We are the often silent, often overlooked, often unrecognized people who safeguard our communities from preventable suffering and death. But as we discussed today, we don't have to be silent. And I see you. And an ever-growing portion of our community see you too. As difficult as this work is, our communities are worth the effort. Our state is worth the effort. Our future is worth the effort. So keep the faith. Know that the work that you're doing might seem small, but it adds up to something great when we're all doing it together. I'm going to put my contact information up on this next slide. If you'd like to continue this conversation further, or if I can be your teammate in this effort. My newsletter follows an NPR style funding model. It sort of follows that NPR style where, the work is really available for free to anybody who wants it. For those who do want to support them, there's a mechanism to do so. I'm also on all of these social media networks. My last name's really hard to spell, and you're probably going to get it wrong, but you will know you're in the right place because the exact same picture is used for all of them. But that really kind of wraps up my comments for today. I, again, just want to thank the UGA School of Public Health for being so kind as to introduce me and for the honor of being here. I applaud the work that everybody's doing, and I think we may have some time for some questions, and I'm excited to answer those.
We absolutely do. Dr. Schmidtke, thank you so much for your incredible talk. And contrary to your social media critic, I'm going to say that we do need your stinking grants. We need them badly. And I think I speak for more than just myself when I say that. But thank you for that wonderful, wonderful message. I'm going to facilitate in the chat window. We have about 8 minutes to have some Q&A. And so if you have some questions that you would like to ask Dr. Schmidtke, now is the time. So please feel free to use the chat window to type your question in the window. And also take this opportunity to complete our first poll this morning. And I'm happy to field those questions to Dr. Schmidtke. So far, Amber, just lots of gratitude and
I'm seeing that. Thank you.
Here's a great question. This is from Dara Balance, and they ask, what one thing would you ask the Georgia legislature for first this session related to the pandemic?
Wow, good question. And trust me, it's something I'm working on every day. I'm in talks with people that are brand new legislators, people that have been in the legislature for a while. But the biggest thing that I'm advocating for right now is money. Every time I'm talking to my colleagues at DPH or GIO or elsewhere within the state government, the people that are kind of helping us through this problem, the thing they keep coming back to is we are out of money. And so for me, the money is really the thing that kind of spurs everything, whether it's hiring more people to do contact tracing or to make tests more widely available, or now in the vaccine rollout, a lot of the problem we're having is we don't have enough people to do the work of administrating vaccines. We don't have a coordination. We don't have administration or administrative support to set up things like appointment lines and other things. So really money is the thing that I'm advocating for right now, but I I would love to see more consistent messaging. I would love to see more from our public health commissioner, Dr. Kathleen Toomey. I think she's doing great work. We just don't get to hear from her enough. And I think that it would provide a lot of calm, and it would provide a lot of credibility to hear her voice more often than we do.
Thank you, Dr. Schmidtke. The next question is from Lisa Roberts. Do you feel local schools should offer testing for COVID-19, or at least private schools who might be able to afford it?
Right. So in a perfect world, we would be testing everybody in the schools, or maybe not everybody, but maybe we would choose a random sample and test those as sort of a surveillance mechanism. We've been told that there isn't funding to do that, that there isn't medical staff at each school in order to be able to do that successfully, and that our public health staff is really kind of stretched thin. So I would love to see that. I will say that my local school district here last week offered free testing to every person in the student body of that school district and their families last week as they prepared to come back for face-to-face instruction. I'm really nervous about them going to face-to-face instruction, but I thought it was really admirable that they were launching an effort to offer testing to everybody. And if Kansas can do that, I don't really know why Georgia can't.
Thank you for that answer. Next question is an important one. How do you address disinformation when the source is high-ranking or a very trusted person, such as a physician?
That is really hard. And I think that for me, go to the data. You know what? The thing is, a lot of the time, these answers can be addressed with data. But the problem with disinformation is they often take advantage of a kernel of truth, a lapse in our data collection, something that we cannot answer, and then they embellish from there. And that's the hardest disinformation to dispel, is where we don't have data to say either way. But I still think that we should try. And I still think that we should say, well, this is what the data suggests, or this is what we know about other viruses and how they behave. But you're right. It has been especially hard. I talked about the team effort of how we're all on the same team. We're all trying to get things through, but it sometimes feels like betrayal almost when you have somebody with medical training that is part of the disinformation effort. And so that's unfortunate, but it is where we are, unfortunately.
Thank you for that. The next question is from Lauren Baggett, our communications director in the college. For first-time scientist communicators, what resources or training would you recommend to help translate complicated topics for a lay audience?
Public speaking. Do it all the time, do it early, do it often. And it can start with talking to your family at the dinner table about what you've learned at school that day, or that sort of thing. I was teaching my younger brother when he was 3 years old how DNA is formed. So I think that the more we can practice talking to audiences who aren't necessarily scientists, the better we get at it. This is just like learning to throw or catch a ball. We don't get there without practice. So I would say start small. I don't have a specific program to point you to. My success has been built on life experience, and I can't really tell you how to get that.
The next question comes from Emily Burnside, and this question is, what do you say to our non-scientists who often compare COVID-19 to the flu?
Goodness, I don't know that anything raises my hairs up as much as that one. And so I first of all, I agree, and I offer my solidarity on that. The reality is that the data show that there really is no comparison. COVID-19 has a lot of symptoms that may look like flu, but that's really where the similarities end. We have a lot more deaths going on with this. I don't know if anybody's seen influenza disrupt their lives the way that COVID-19 has, but there's really just no comparing the two data-wise. The unfortunate thing, like I said, there will be some people who find data to justify their narrative, regardless of what the scientific consensus says. And we've seen that. We've seen people say, oh, well, the excess deaths are not as bad as they were, but they're really only measuring a partial year as compared to a complete year, and things are not even close. And so I guess what I would say is I just go back to the data. And that's really my default answer for a lot of these disinformation efforts.
Here's a question in particular about regulatory bodies. This is, do you feel that regulatory bodies are best served by being an extension of the executive branch, or do they need to be independent bodies going forward?
That's a good question. And I don't know. I can see an argument for having them branch off and be more independent. I think that would do a lot to restore public confidence in our regulatory bodies, and it would perhaps limit the ability of big donors or big industries influencing things. And we see this a lot in the food safety industry in particular. So that's what makes me think of it first and foremost. So I don't have a good answer for that. I'm going to think about that one. That's a good one.
Here's another question. This is from Jeanette Hill, and it's actually related to another question. I'm kind of going to bundle two together here. You noted in your latest posting that, of course, that we're in a surge in the state of Georgia, in particular in Clarke County. What recommendations or suggestions might you have for us as a community as we have many people returning to campus and many people returning from holidays?
Right. I'm super nervous about what happens for AthensClarke County. I'm sure that many of you are too. I guess what I would say is, if you are able to shelter in place, if you're a person who is over 65 or has underlying medical conditions, we just know that there's a lot more disease now than there was in August. And so if you're in one of those people, then as far as the continuum of risk goes, you're probably going to want to be on the more cautious end of things. But really, we need, like I said, the solutions we have are slow, but not necessarily wrong. Things like non-pharmaceutical interventions, they aren't as satisfying as a vaccine that's massively rolled out, but we're not there yet. And so we just need more people to do the work that we've been doing this whole time of remaining socially distant, wearing their masks, and really paying attention to symptoms. I think UGA has some things going for it in the sense that they've got their surveillance testing that they're doing. I hope that can ramp up or even accelerate to better protect that community. But I know that those students coming back are an important economic driving factor for the area too. So it's really a hard thing, and nobody enjoys this pandemic. I'll just say that first and foremost. We're all ready to be done with it.
That's absolutely right. We have reached the end of the time that we've allotted for question and answer. Thank you for those who submitted questions. And also, again, just thank you, Dr. Schmidtke, for your wonderful talk. It has dovetailed beautifully into what is our next part of the conference, which are our breakout sessions. So thank you again so much. Just a note for our participants, please do not log out, because your login information is connected to the breakout sessions that you are registered for. So now we're going to have a 10-minute transition into our breakout session. Hey everyone, welcome back. Again, my name is Grace Bagwell-Adams. I'm the Assistant Dean for Outreach, Engagement, and Equity in the College of Public Health at the University of Georgia. It's my great honor to introduce our next speaker and artist. With us today, we have S.J. Henderson. S.J. Henderson is also an alum of our program at the University of Georgia. She just finished her dual degree program in Master's of Social Work and Master's of Public Health, which is an incredible accomplishment. And when she was a student here, finishing up her degree, she actually was a recipient of a very special fellowship in the Shelter Projects program that's co-sponsored by the Wilson Center for Humanities and Arts in partnership with the University of Georgia Graduate School, UGA Arts Council, Franklin College of Arts and Sciences, and Flagpole Magazine. And these fellowships support graduate students and community-based artists and practitioners in the creation of shareable reflections on their experience of the current pandemic through the arts and humanities. So as a product of that, SJ has actually produced some spoken word art that she will share with us today, entitled Define Pandemic. And when we were meeting to discuss her performance, I asked her how she got into spoken word, and she told me a wonderful story about how it actually was in the 4th grade is when you were invited, I believe you shared, by your school principal to perform at the 5th grade graduation. And so truly this is a lifetime of passion that you have now married with your skills, passion, and training in public health, which is just amazing. So again, just deep gratitude for sharing this with us today, SJ, for sharing your time, your talent, and the work that you've produced, which is so incredible. And I also want to say that SJ is also looking for a job now that she has graduated. And so I have invited her to drop her email in the chat window if anyone wants to reach out after the performance with questions about the performance or with opportunities, because she is incredibly passionate about environmental health and social justice. And so I think you'll see that reflected in her work today. Again, welcome, SJ. Thank you so much.
Thank you. So a little introduction to my poem. My poem was inspired by my public health capstone. I conducted a literature review that examined exclusionary housing policies, infrastructural violence, and poor health outcomes in Black communities. It was entitled Environmental Racism and the Contamination of Black Lives. It was recently accepted for publication. I introduced the paper by talking about Freddie Gray, a Black man who died in police custody and whose story went viral due to the way in which he died. I take this story of police brutality and add to it by discussing infrastructural violence that he endured during his life. He and his siblings tested positive for lead poisoning as children. They lived in a food desert, attended significantly underfunded schools. And so while I honor the stories of Black lives lost and I respect the ways in which people mobilize to advocate for those tragic stories, I want to also make sure we are thinking about the way that Black communities are often forced to live. So this poem is inspired by that capstone project and the movements for racial justice that we witnessed this past summer. And it's called Define Pandemic. It's easy to criticize protesting during a pandemic when your 6 feet is apart and our 6 feet is under. No wonder. When you're worried about dying and we're worried about being killed, don't tell me how I should feel. I sit in my bed at night and try to wrap my mind around the idea that some people can be completely outraged by Colin Kaepernick taking a knee on a field and completely comfortable with an officer taking a knee on a man's neck as he lay still. It's unreal. By now, Black people should be experts at distancing themselves, seeing as how they've been forced to exist on the outskirts of the American dream since before its conception. Where do you go when no safe space exists for you? What do you do when freedom keeps missing you? What do you say when in the middle of a worldwide crisis, you're reminded that you're still just a Black life that does not matter? I am scared. I am confused. I am hurt. I am upset. I am sad. I am not hopeful. From peaceful protests to armed and ready, from revengeful thoughts to hearts heavy, from resistance to compliance, from complacency to defiance, they have found so many acceptable ways for us to die and none for us to live. These isolated incidences sure do come in great numbers. I sit in my bed and I wonder if they really want us to stay home because they care about our health. The health of Black America was not important when you found out there was lead in the water in Flint. It wasn't important when you found out about hookworms in Alabama. It wasn't important when Beatrice Holt from Dickinson, Tennessee discussed generations of her family getting cancer because of toxic wells the EPA insisted were safe. These are all cases where the cities were either predominantly Black or worse, they weren't. And yet somehow all the environmental hazards still ended up in the Black neighborhoods. Must be a coincidence. But you would rather critique the people that resist instead of addressing these inequities that persist. The health of Black America wasn't important in 1983 when the General Accounting Office showed that hazardous landfills were most likely to be placed in Black communities. It wasn't important when the EPA report in 2018 concluded Blacks are still at a higher risk of being exposed to environmental hazards. Where was all this pride for our country when Black veterans returned home from World War II only to be afforded living circumstances that didn't meet the minimum requirement of health or sanitation? Denied their quote unquote guaranteed mortgage loans because of exclusionary housing policies that didn't care if you were a Black man who robbed a grocery store or a Black soldier who put your life on the line for your country. Being Black is a difference in the government giving you money to keep you poor and giving you money to build wealth. But now you care about our health. Great. My poems are usually more poetic, composed of lines that make you go ooh and ah and snapping fingers and clapping hands, but I am not trying to entertain you today. As I lay in my bed and I think about this pandemic, I cry, I rock myself to sleep, wondering if I will survive it. I think of the many that have died, the many that have suffered traumatic experiences, the families that have been torn apart, the adequate health care that for one reason or another may not have been afforded to them. And I think of how you, probably still do not realize the pandemic that I am speaking of. Thank you.
SJ, thank you so much. I think that it's only appropriate, given the opening remarks of Dean Davis and the work just shared by SJ, that we just take a moment of silence to remember those that have been lost due to inequity and disparity. Thank you again, SJ. That is a beautiful and meaningful segue into our final closing keynote. We are joined today by Dr. Renée Canady, and I'm going to now introduce you, Dr. Canady. Share with our audience a little bit about your background. Dr. Renée Branch Canady serves as the Chief Executive Officer of MPHI, a Michigan-based and nationally engaged nonprofit public health institute dedicated to advancing population health through public health innovation and collaboration. Dr. Canady has been recognized as a national thought leader in the areas of health inequity and disparity, cultural competence, and social justice. She has published and presented broadly on these topics, and her passion for this work is evident in her personal, academic, and professional life. Dr. Canady has been highly influential in broadening the discussion of health equity and social justice while serving on numerous national boards, review panels, and advisory groups. We are honored again, Dr. Canady, for your presence with us today, and we so look forward to your remarks. Thank you for being here.
Thank you, Grace. And wow, SJ, make sure you see my message in the chat. That was fire. Boy, what a day. I typically am not able to do the whole conference when I'm invited to speak, and I'm so grateful that today's schedule allowed me to accommodate that. I've grown, I've been stretched, and I've thought a lot. So I'm going to try to be, I think, a pretty comfortable bookend to Dr. Schmidtke's opening and send you some off with some marching orders. And in the spirit of her, Dr. Schmidtke, living with a military man as spouse and I living with a military man as father, I think we are perfectly aligned to do that. So let me see about sharing my screen and we will dive right in. Grace, can you tell me if the right image is showing? If I need to do
Dr. Canady, it looks good. You just want to go to presenter mode, but we're
go
seeing
to
your
presenter mode,
slide editing mode.
There we go. Perfect. Thank you, Josh.
It didn't go.
It did not go.
It's still in the slide edit mode.
Let's see here.
It might be a two screen. Let me go ahead and share it.
Well, I'd rather share it.
Okay.
Let me see if I close one screen, if that helps. Did that do anything?
No, I think it's picking up you're probably gonna, there you go. Great. Looks great. Thank you.
Got it. Okay, super. Thank you. Technology is our friend sometimes, and other times, well, y'all know. So listen, today we've been talking about the state of the public's health, and I want to close us off talking about the state of the public health equity leadership. And in case you're unclear, that is you. I am talking about you. And my goal is to give you some frameworks to just think about in the next stages as you leave here, going back to work or engaging in your work tomorrow. So, in public health, we have had a relatively, and I'll say overly simplistic model about health, right? We talk a lot about what does it create? What does it require to create health? Well, we want to make sure people are eating healthy, right? So we talk about things like food insecurity. We want to make sure people can see a physician. So we talk about things like healthcare access. We're now even talking about sleep deprivation. And of course, exercise and fitness has always been a mainstay, but we also know that those things get complicated by context, right? The context that is beating our land deeply, and we are all experiencing it in some ways the same, but in other ways very differently. We're also experiencing another pandemic that we knew was always present, but somehow or another, we convinced ourselves that we didn't have to talk about it. And honestly, as I looked at my pictures last night, I was going to flip out and put pictures of all that the trauma we experienced together last week. And honestly, it was just a little too fresh right now, but I hope you recognize these scenes of this pandemic of racism that so many of us are experiencing and living together. It seems like a dark time. But in the midst of darkness, as Francis Bacon says, that is when the light shines. And I think about all the dark times that those who paved the road before us dealt with. And I love so many of the things that Dr. Martin Luther King said. And this is one of his quotes, and I would dare say he made it during a dark time, but he said, "I have the audacity." I love that word, SJ. There was a ton of audacity in that spoken word. And he said, "I have the audacity to believe that peoples everywhere can have 3 meals a day for their bodies, education and culture for their minds, and dignity, equality, and freedom for their spirits." And I just invite you to just have the nerve to believe with me and with Dr. Martin Luther King, as he did, that things can and will and must get better. But we're stuck in these frames of thinking, right? Abraham Maslow, who most of us know from Maslow, if the only tool you have is a hammer, then I suppose it's tempting to see everything as a nail. These mental models, which are deeply, deeply held beliefs about how the world operates, we have them in public health. And we also know that there are many people in that public that we serve that have very different worldviews than ours. And so how do we, as public health leaders, bring ourselves to a place of reconciliation and conciliation that allows us to advance our responsibility for protecting the health? I'll leave you with, I want to just share with you one study that Howard Koh did on public health leaders, a study he did about you, because remember, you're a public health leader. And then I want to make sure that we are sharing a similar understanding of terms that get bantied about in this dialogue. So Howard Koh says that in his work, there were 2 characteristics of leaders in public health. One was that they are generally driven by a profound sense of mission, this fundamental sense of mission. As Dr. Schmidtke said, we're not running into public health to get wealthy. There is mission and there is purpose in what we do. And the second thing he observed, and I feel both of these, that public health leaders are generally moved by a sense of purpose that motivates them to leave the comfort of the sideline and wade into controversy. A pandemic will require you to do that. But we do that, I would submit, in our everyday work. And so as we think about the challenges that we face as public health leaders, Cole also described some characteristics of public health problems. One, he said, they're enormous in scale. Okay, yeah, my job is to fix a pandemic today. They're enormous, right? Almost to the point of feeling overwhelming. Public health problems also stem from numerous and very complex causes. There is not a silver bullet laying around. There's no one simple response. It is challenging. These problems play out in the public, and I certainly believe that public health is governmental. There is much that we do in other aspects, academic public health, nonprofit public health, research public health, consulting public health, lots of other spaces, but the rubber meets the road in governmental public health. And when you report to an elected official, as local health officers do, as I did when I was the director of the Ingham County Health Department, your life comes with another whole level and layer of challenges. Public health problems, Co says, also impact a vast array of stakeholders. So there are a lot of people that we are trying to attend to, a lot of people with diverse needs and diverse priorities. And lastly, he said that they require unusually long-term solutions. This is not going to get fixed tomorrow. It's not going to get fixed in the life of our 3-year grant cycle. To my philanthropy friends that are at the conference, it's complicated. It requires, because of that, a level of vigilance that we sometimes lose in public health. We try to move on when the headlines move on and the problem has not moved on. Interestingly, as we've begun this dialogue in public health of racism, also as a public health pandemic, it struck me that racism also poses these same challenges. Lots of stakeholders, enormous in scale, playing out in the public, taking forever to solve. But that simply means that we've got to sort of dig in our heels and stick with it, understanding that racism has been the root of so many threats to our health and our well-being in this nation. So let's talk a little bit about how we talk the talk, right? I would submit to you that everybody saying health equity is not meaning health equity. And I think the best way for us to understand health equity is to understand its evil twin, health inequity. And I love this definition by Margaret Whitehead. And Dr. Whitehead says that health inequity are the differences in population health status and mortality rates that are systemic, they are patterned, they are unfair, they are unjust, and they are actionable, as opposed to being random or being caused by the people who are ill. I love that Dr. Whitehead invited values to the table. We try so hard to be neutral in our work, but we have a point of view. We have an opinion in the matter. And we believe that inequities are unfair, they're unjust, they're just not right. And we have to, because of that, do something about it because they are actionable. Fix poverty, fix racism. Well, both of these things are socially constructed. So absolutely, yes, we can. I was pleased that to be in the health equity breakout session. And if you don't know the HOPE measure, be sure you watch that video. It's such an important methodology and tool for you in your practice. But in that work, we, and I say we because I had the privilege of being on the National Advisory Committee, we landed at Paula Braverman's definition as really being tantamount to what we were trying to aspire to. And that definition says that health equity requires removing obstacles to health, such as poverty, discrimination, and their consequences, things like powerlessness, lack of access to good jobs and fair pay, quality education, housing. We are talking about the adjectives here, not just, oh, let's get a job, but how about a quality job? Not just are you being paid, but is your pay fair? And I love that Dr. Braverman said that health equity is the moral drive that pushes us to address health disparities. It is the so what. So let me throw out just a couple of agitational points for you to think about, a few nuggets to take home with you, if I could. Just kind of peek at my time here, my little timer. Okay, we're doing good. My chief financial officer introduced me to this concept. It's an accounting principle called tone at the top. And she noted that in companies that are at risk for fraud, if you go to the senior leader and look at what type of tone of permissiveness or as being cavalier, if you look at that tone that's being set, it's a pretty good indicator of potential fraud and financial risk in those companies. What type of tone are you setting from wherever you sit in your organization? Because again, you are a leader. Your sphere of influence may be directly on the ground doing the work. Your sphere of influence may be supporting the people who are on the ground doing the work, or your sphere of influence may be very much similar to mine, that senior leadership that's helping to set priorities and direction. What tone, what culture, what mood are you pressing and allowing in your organization? I think Dr. Schmidtke also, and certainly in the health equity breakout, we talked about relationships. I absolutely believe that we were created for relationship. My favorite relationship quote from a mentor of mine, Ron David, Dr. Ron David says, relationships are primary. All else is derivative. There is nothing that we accomplish outside of relationship. And how authentic are the relationships that you're creating? We're in a lot of different relationships, but are they meaningful and powerful? Let me push you as a leader to live your life, do your work in a way that earns trust. Respect and trust are earned, they are not given. So sometimes we get a little frustrated about why don't they trust us? Well, Tuskegee was years ago. That's ancient history. Nope. It might be ancient history, but we've not yet done anything to reverse the impact of that history on our relationship. And as an aside, although African American, Native American, many communities of color have significant cause to not trust government and to not trust people in power, I would submit that we have evidence now that trust is lacking across demographics of our society. What we saw play out in DC was a clear demonstration of lack of trust. Now, we have lots of different opinions about why those actions took place in the way they did. But it's not just Blacks. We want to say, well, we did Blacks so bad, so they don't trust us. No, trust is an issue for everyone in this nation, and we've got to own it as a shared problem in public health leadership. Let me submit to you that you cannot fake it until you make it. I have this Ph.D., and when I'm called doctor, sometimes people mistakenly think I'm a medical doctor, a physician, and I always say, well, I play one on TV. But I have just enough knowledge to be dangerous. No, don't tempt me to practice without a license. I don't want to fake it. Again, Martin Luther King said, you have very little influence with those who feel your underlying contempt. You think that you're coming across sincerely, but they know. They're seeing how you look askew when they speak. They're seeing the slight roll of your eyes or the piercing of your lips. People know when you are not being sincere, and your leader. The responsibility and the burden is on you. Couple more. The fairness oxymoron. In this country, right, we decided that fairness is an important goal, but we've also decided that sometimes the most unfair thing we can do is to treat people the same. People are not the same. We have very different experiences. We have different needs. We have simply different wants. And what is our responsibility? To give ourselves permission to not treat everyone the same. So when you hear a clinician or a therapist, a lot of people in the helping profession will say, I treat all my patients the same. Shame on you. All of your patients are not the same. And so even in research, I mean, I bristle always at the concept of fidelity to model, because the fidelity to model says treat everybody the same. Nope, nope, nope. This is the way the model goes. How do we stretch ourselves in clinical practice, in research, in public health practice, understanding that it's our responsibility to meet people at the point of their needs, not at the point of our convenience. Another sort of standard, this issue of privilege and power, and I submit that the paradox of those two. Sometimes when we get in power, we think this is great, I'm on easy street now. But the higher you get in an organization, the more that's required of you. To whom much is given, much is required. You have more knowledge. You have, I would submit, more political cover. I say often, I try to get my team riled up, speak up, stand up, do the right thing. But sometimes I'll say to some of my colleagues who have less positional authority, let me say that. The mouthpiece matters, because then I don't want you to have any fallout from making this very important and legitimate point. Let me say it to sort of break down the barriers, and then you plow through. Let's be strategic, right, in how we use our power and how we use our privilege. We know that privilege is unearned, and that's a confusing concept if you're saying, no, I went and I worked hard to get this master's degree, this PhD. But there's also positional power, gender power, racial power that just comes because of who you are. And if it's unearned, then there's not much you can do to get rid of it. And so how are you then going to apply it and to use it? Let me push you to pick a side. As of late, I'm really, really irritated by cowardly leaders. And I feel like we see a lot of them on the TV as of late, just not willing to speak truth to power. So pick a side. We need you to do that. And let me just submit, it is worth the risk. It is risk-taking, but it is worth the risk. And so in my frustration, right, as I'm thinking about, man, why didn't they speak up? They had that opportunity to say that and they didn't say anything, or why didn't they do this? And I started really trying to come from a place of both compassion and curiosity. Sometimes as a medical sociologist, I lean on what we call our sociological imagination. Let me just reflect on this for a moment. And so I started thinking about risk-taking and why leaders were not speaking up. And I came across this work by Margie Worrell, and she talks about 4 things that keeps leaders from speaking up. And the first thing she says is, we overestimate the probability that something will go wrong. The likelihood that the bungee cord is going to break if I jump on it, et cetera, et cetera, et cetera. We overestimate the likelihood that something's going around. Secondly, she says, we exaggerate the consequences of what might happen if it does go wrong. It might go wrong. The elephant might fall off the tightrope. But there also might be a bunch of bushes or a lake or a bunch of mattresses. Don't go wrong. Thirdly, she says that we underestimate our ability to handle it if it does go wrong. You can handle it. You're equipped. You're equipped academically, intellectually, but I would also submit that you are equipped intellectually and affectively. Your feelings, your motivation, remember that passion that causes you to wade into controversy, all of that equips you to handle things if they go wrong. So take a risk. And lastly, and I would submit most importantly, she says that people don't take risks because they discount or they deny the consequences of inaction. That's a big one. If you are sitting in space, just sort of in a status quo sort of context, like this is good enough, enough, stop it, take action, take a risk. The public, and I would submit your family, is depending on you to do so. So let me just end with a couple of quotes. I love these two quotes that I'm going to give you. Antoine de Saint-Exupéry, French aviator, says, if you want to build a ship, don't drum up people to collect wood and don't assign them tasks and work, but rather teach them to long for the endless immensity of the sea. That endless immensity of the sea is health equity. That endless immensity of the sea is social justice. It is a place where all men and women are created equally. It is the America that we are hoping and longing that we will be. We instead, as leaders, get socialized and taught to assign tasks, drum up people, get people to come to the committee meeting, make sure they have all the resources they need. Do they have the wood? Do they have the hammers? Do they have the nails? That is not how systems change happens. Drive them to the vision, push them with their passion. And let me just complete Martin Luther King's quote that I started with, right? He did say what I said at the beginning, and usually that's where the quote ends. But if you continue reading, he says, yeah, I have the audacity to believe that peoples everywhere can have 3 meals a day for their bodies, education, culture, minds, and dignity, equality, and freedom for their spirits. But he went on to say, and I believe that what self-centered people, he said men, what self-centered people have torn down, other centered people can build up. Man, just saying that quote in this context right now of shared trauma that we are all experiencing. I'm just feeling, I'm having a goosebump moment. You are those other centered people. You are the ones that can build it up, can restore it, can rectify it, can bring in community, writ large, all of us, solving not in the same way, but in a way that makes us stronger, makes us better, and makes us capable. It's not easy. One of my favorite Old Testament quotes says, be not weary in well-doing. Don't get tired of doing the right thing. But the risk, the efforts, the sleepless nights are worth it. And if we were planted in history at this time, then it is your responsibility as a public health leader to pick up the gauntlet and do what only you can do. The state of the public's health leadership, I would submit, is strong, and it is good because of the many interactions I've had with colleagues like you. Thank you all so very much. Thank you for prioritizing this event in your day. And I am looking forward to engaging you in other contexts. I assume you have access to these slides. There are a couple that I want to just let you know are there. And actually, since we can't do Q&A, I do want to ask you to do one thing for me, right? You are a change agent. You are a health equity change leader, change agent. So if you could, in the chat, as you reflect on today's content and think about what is particularly relevant or stimulating in your work, I want you to think about that. But in the chat, I want you to also put a one feeling word that describes where you are right now as a public health leader. What feeling, right? This is head and heart work. Head and heart work. How are you feeling right now? And what will you do as a first step to change? So throw those in the chat for me. And Grace, I just want to thank you so much for the invitation. I feel empowered and equipped by this exchange, and congratulations to you on a great day.
Dr. Canady, I cannot express my gratitude deeply enough. Thank you so much for these beautiful words. I think that I'll just borrow a few from the chat window that I'm seeing here. Inspired, relentless, informed, determined, fearless. Just a beautiful word cloud that's being created by all the participants here. So thank you for giving us that gift as we depart. And just in closing, for our audience, just want to say, I myself have taken so much from this day. Some of the things that stand out, the charge from Dr. Amber Schmidtke to be approachable and available. I attended the health equity session and was really inspired by the work of the HOPE initiative, and remembering that health behaviors really need to be sort of removed from our approach to solving systemic inequity. And last but not least, hearing from SJ, your incredible work and your art, and the gravity of that, paired with Dr. Canady's closing remarks. And I think it is hard to feel hope. But, I think hope is in the fact that a lot of these issues are actionable. And I take heart, even virtually, in being surrounded by so many people who are doing actionable work, who have the moral drive to address health disparities, borrowing again from the definition that you shared from Paula Braverman, Dr. Canady. So again, we have much to do, but our hope this morning was to motivate, to energize, to empower as we embark on another year of public health, kind of going into the unknown, which is a song often stuck in my head because of my 3.5-year-old daughter's affinity for the movie Frozen, Frozen 2. But I do feel like that's where we are as public health professionals, just kind of leaping into the unknown. My last job for today, before I turn it over to Dean Davis for closing, is to just extend our deep gratitude for the village of people that have made this conference possible today. First and foremost, the Healthcare Georgia Foundation, thank you for your support. Vincent LaFranza with the National Network of Public Health Institutes, our incredible technical assistance team, also from the National Network of Public Health Institutes, that includes Carmelita Mero, Josh Klein, and Rick Bloom. Thank you to Becky Ayer for really leading the communication efforts, and also to Lauren Baggett, our communications director. We thank the planning team, Dr. Heather Padilla and Ben Morrison. And I also just want to thank personally Dean Marcia Davis for trusting me in this role. And you certainly have developed a wonderful conference for all of us to come together. And so it's my honor to help you with this as we move now into planning our 10th public health conference that will follow this one. Thank you to each of our speakers and breakout presenters, and to also the moderators for the panel. And I also just want to say, last thing before I turn it over to Dean Davis, it is our great and fervent hope that by October of this year, we will be able to come together again in person for our 10th State of the Public's Health Conference on October 21st of 2021. So 10/21/21, mark your calendars. You'll be hearing from us soon via email, I have no doubt. And remember that all of what you've seen today will also be made available online. So please watch and share. And thank you again. And Dean Davis, I turn it over to you.
Thank you so much, Grace. And let me echo all of your thoughts. I wanted to take this opportunity to give a special thank you to Linda Moak. You know Linda from working with me over the last 9 years. She's been through all 9 of our conferences. Unfortunately, this year you didn't see her at the registration table or ringing the bell or greeting you at lunch. But she is here, and I want to acknowledge her dedication to the conference. She will be retiring in February. So thank you, Linda, for being with all of us during this journey. And Dr. Canady, I will try with my closing. I'm having a goosebump moment, but I'm also having a tear moment. So I am grateful for all the work that we all are doing to promote health in Georgia. I want us to go forth this year. We're often overwhelmed and tired, and it is a long journey that we're on. But I encourage us all to go forth with resiliency, with perseverance, in solidarity, and with hope, and the belief that each day that we work with all to promote the health of all will result in exactly our dreams of a world of equity for health for all. So again, I thank you. We will be in touch. And as Grace said, I hope in a year that we will see each other in Athens. Thank you so much.